speak about science, writing, ideas, creativity. So first thing when you want to do a research project is the idea. And ideas have different general families of what they fall in. There's ideas that are novel and innovative, that just come out of the sky. Those are very, very rare. Most ideas are adaptive or applicative, which means you're extending someone else's thoughts or adapting something that's been created. So don't try and search for the blue sky idea that changes humanity. One person in this room maybe do that one time in their life. Most ideas come from reading slightly related literature and then adapting something that was seen somewhere else. So spectroscopy was first used in the brain, then someone uses it in muscle. That's not a novel idea. That's an adaptive idea. It's an important idea, but it's an adaptive idea. And then someone uses that in a soft tissue tumor. That's an adaptive idea. So there's novel ideas, there's adaptive ideas, and there's applicative ideas. So an applicative idea would be, I have a sequence that I've used in the knee, and now I want to use it in the shoulder. It's just bringing it up one slight step. Now, where a paper is published is 1/3 how well you do the study, and 2/3 how novel the idea is. So the idea has to begin first. Now, when you have an idea, it has to have, or preferentially should have, some importance clinically. And the importance clinically may be potential, like I'm reading a bunch of grants this morning on imaging for osteoarthritis. And the premise on all of them is we will develop new drugs that help osteoarthritis. And since we will develop new drugs, we need better ways of following osteoarthritis. Now that's a potential application. It's a realistically potential application, but it's a potential application. So when I have an idea, that idea could be new or could be adaptive, but it has to address a clinical need. So what is a clinical need? Well, a clinical need is evaluation of that disease is either invasive, costly, limited availability, or takes too much time. Now that assessment may not be imaging. That assessment may be a laboratory test, it may be surgery. So don't limit the comparator assessments to imaging. But the critical need is that what we do now is not good enough. Now sometimes there's nothing that we do now. So when CT first came around and they were looking at brain tumors, there was nothing that we could do to see brain tumors. So sometimes the need is there because it's completely blind to us. And in the end, you want something that will help to diagnose, monitor, or affect treatment of a disease. That should be the ultimate goal. Now, the ultimate goal may be 100 years in the future, but the ultimate goal is to treat disease. So in America, there's a medical research institute called the National Institutes of Health. Has anyone here heard of National Institutes of Health? The NIH. So how many of you think the purpose of the NIH is to fund medical research? Most people would say the purpose of the NIH is to fund medical research. The purpose of the NIH in their charter is to improve the health of Americans. That's the purpose of the NIH. Think of that purpose whenever you have an idea. Your idea should improve the health of a population. It's not to do research, it's to improve the health of a population. Now, your idea can be a technique, an observation, observation, a unique application, a unique population, or improved research methodology. And let's walk through this for a minute. So I invented MRI. You may not know this, but let's pretend for a minute that I invented MRI. I will now write a paper on my invention of MRI. That is a technique. I describe that technique. That's a technical development. Now I've invented MRI and I see something on the images. I don't really have proof of what I see, but I see something. I now write a paper on what I see. That is an observation. That's the next stage of technical development. Now I see something, and I want to apply this thing to rotate a cup. I'll then have surgery comparing it. So I'll have surgical proof, and I'll compare my technique, my observation, to a standard of reference. That becomes a unique application. The next stage of technical development. Now, there's 100 papers on MR the rotator cuff. I want to write the 101st paper. How can I write the 101st paper? Well, I have a unique population because I know this parasite affects the rotator cuff, and I happen to have 50 patients who have this parasite. So I now have a unique population. No one else has ever studied that population. That's the next stage in technical development. Everyone understand those stages so far? Now, I want to write the 102nd paper on it. It's no longer a new technique. It's no longer a new observation. It's no longer a unique application because there's 101 papers on it. I don't have a unique population. But what I do have is a good mind for science. And I look at those 100 papers, and they all had defects in their methodology. And I'm going to do the methodology better. And if you look at papers, 99.99% of papers have defects in their methodology. You could always do the methodology better. Almost no one, particularly in imaging, does methodology even okay, let alone good. So my idea can be a technical description, it can be a proof of concept, it can be a theory with potential, that's a preliminary observation. Or we all hope that it's a landmark study. And a landmark study is landmark because it selected a good population, it has large numbers, it's a rare disease, and I have acceptable numbers, and it's a rare disease. Or most importantly, I have pure methods. I've studied this problem perfectly, and the focus of this is going to be how to study this problem perfectly. So the different types of papers are technical development, case report, or series, and they're basically the same thing. They're collections. And collections are intrinsically biased. So I collect stamps. I only like stamps that have airplanes on them. And if someone would see my stamp collection, they would think that all stamps had airplanes on them. Well, very few stamps have airplanes on them, but I just happen to collect stamps that have airplanes. And that's the problem with case series. They're always selected, and therefore they are unnatural. A letter to the editor is an often good way to start getting published. I just became editor-in-chief of a journal, JMRI, and one of the things I said in my interview is I want to encourage letters to the editor for two reasons. The first reason is it creates a conversation between the readers of a journal and the journal. Rather than the journal just throwing papers one direction, it's now a conversation. And the second reason, it's a great way to start writing. So you get people excited, you get them to begin writing, rather than trying to write a paper which chances are won't be accepted. Then you have review papers, state-of-the-art, pictorial essays. That's not science. That's education, but it's not science. because it's very important to put research into perspective. And a paper, by the nature of scientific writing, cannot put science into perspective. Someone other than the author has to put that science into perspective. And it's a very important role of journalism is to put science into perspective. So let's begin. We have our idea. We figured out how to do it. Let's begin writing. Now, a lot of authors will tell you they started with a title and then changed the title, or started with a fake title. Authors of books. I think you should begin with your title, because your title focuses you. And when I look at titles, I change them when I edit about 80% of the time. And it's not only do I have to change the title, because I have to change the title, I think the authors weren't focused, because they didn't select the right title. If I can make the title better than the person who wrote it, something is wrong. I like titles to be a question. I don't like them to be long. I like them to catch your attention. And then a title should often say what the work is. So my title may be, does T2 MRI help you diagnose rotator cuff tears? That tells you everything you need to know about the paper, but doesn't give you the answer. It's short, it's complete, and it's a question. Be very aware of using the words predictive, impact, role, novel for the first time in titles as well as in text. Let the reader determine if something is novel. Let the reader determine if it has impact. Almost nothing is ever done for the first time, and it's very arrogant to say that. Predictive can only be done prospectively, and almost no imaging studies are prospective, so almost no imaging studies are predictive. They are associated. So I often begin a title with the disease, colon, and then a question. So I'm going to give you a research idea, and you're going to give me a title. You ready? You ready? So I want to study osteosarcoma, and I want to see if carbon spectroscopy can differentiate the different types of osteosarcoma. Can anyone give me a title? So osteosarcoma, colon, does carbon spectroscopy correlate with biologic activity? Question, right? My title says exactly what I'm going to do. Short and scientifically valid. Everyone understand that? Just made that up on the spot. So once you have your title, you want to introduce. And an introduction introduces. It introduces your idea. And that's why we began with your idea. It does not introduce the disease. So if I'm writing my paper on carbon spectroscopy of osteosarcoma, I have one or two sentences about osteosarcoma in my introduction, no more. I have 3 sentences about spectroscopy, no more. 1 or 2 sentences about what else may be done to predict biological activity, and then I get to my purpose. So in this paper, osteosarcoma is a relatively common osseous tumor of childhood, predominantly of childhood. Sentence 1, it has variable prognosis, based mostly upon the histologic appearance. Sentence 2, the best way to determine the prognosis currently is blank, blank, blank. Sentence 3, new paragraph. Carbon spectroscopy is a recently introduced methodology to evaluate for blank, blank, blank. It has been used to evaluate for biological aggressiveness outside the musculoskeletal system, blank, blank, blank. tumor, since we are not able to prognosticate well, comma, since carbon spectroscopy has been shown to be useful for prognosticating outside the musculoskeletal system, comma, we sought to apply carbon spectroscopy to osteosarcoma. That's the introduction. Nothing else. Right? What was that? 6 or 7 sentences? Everyone with me? What needs to be referenced? Anything that's not common knowledge needs to be referenced. If you say authorities disagree, many say, anything with a plural in it, you need at least 2 references or preferentially 3. Major mistake is people don't reference. Okay, so we did the title, we did the introduction, now we're going to do our methods. Again, it helps to organize before you write. So your first sentence of methods is your first section of methods is your population. Your second paragraph is imaging. Your third is imaging analysis. Your fourth is correlation. And your fifth is statistical testing. Okay? So first section is population. Prospective, retrospective, over how long, where did you get them from, how did you get them? That tells you the bias, what's called external validity. Okay? List the ages and the genders. That's your population. That tells you what's called, I just said it, external validity. External validity means, can my results be applied somewhere else? So if I'm studying a population in central Ottawa who has unique genetics, they may not work in a population in central Cairo who has different genetics. That's called external validity. So that's why that one goes first. The second part of your methods is imaging. The type of equipment, the type of software, the type of sequence. That's imaging. Basic nuts and bolts. When it's all numbers, like imaging techniques, put it in a chart or a table and just synopsize it in your text. Say T1 and T2 weighted images were acquired, see table 1. It's very hard to read something that says TR blank, TE blank, field of view blank, matrix blank, slice thickness blank. You just can't read that, it's all numbers. So it doesn't help the reader to put that into prose. So first paragraph, population. Second paragraph, imaging technique. Third paragraph, image analysis. Who read it? What were their qualifications? Was it 1 sitting? Was it 2 sittings? Did they look at all the signs together? Were they blinded? Did they know the initial reading of the x-rays? Did they know the idea of the study? All these things have an effect on imaging and how it's interpreted. So, like a key concept is if you're testing a new technique versus an old technique, and on my first sitting, look at the old technique, and on my second sitting, look at the new technique. The new technique is always going to be better. You know why? Because we're smart and we learn. So you sit on the first sitting and you learn, and by the time you read it the second time, you're better. So if I read the new technique first, and the old technique second, the old technique would come out to be better. Whatever's read second almost always comes out to be better. Everyone understand that? So how you mitigate that is that sitting alone, you read half of the new technique and half of the old technique. And on sitting 2, you read half of the old technique and half of the new technique. So now that concept of learning is mitigated because you're reading half and half. So how the studies are read has a huge impact on your methodology. And I said earlier, I want to write the 102nd paper. The way you write the 102nd paper is you do your image analysis better. Most of the images analysis concept of verification bias. So I'll give you an example. I'm doing a new technique on rotator cuff tears, and I want to validate this. So I need to prove I see what I see. So I only take patients who went to surgery, because now I have a proof. And I find out my method is 90% sensitive. What's the problem with that? It's a more severe disease. It's a verification bias. I selected patients who went to surgery, so my sensitivity may be 90% because 89% of them already have rotator cuff tears. My sensitivity may end up being only 10% if I do all patients. So that's called the verification bias. And the verification bias comes from the fact that we want some good standard of reference. So you have to balance your need for a good standard of reference for the possibility that you'll have verification bias. So a lot of papers that I edit, I'll say, go back and look at 50 patients who have a 3-year follow-up that shows they didn't get worse and that don't have a rotator cuff tear, and compare those patients to prove that it works in real life, that it has external validation. That's image analysis. That's a very, very important part of your methodology. And the last part of your methodology, I just said is correlation, I'm sorry, not image analysis. What you use is your standard of reference. The last part is statistical analysis. And no one in this room can do statistical analysis, I don't think. You really need a statistician to do statistical analysis. If anyone tries to do it themselves, you're going to be wrong. You just don't have the database to do it. Now, I often tell people to write your methods before you begin your paper. And they look at me like I'm crazy, which they often do. But in this situation, I'm not crazy. Because that's the purest methodology. Because if you write your methods after you write your results, subconsciously you change your methods to fit your results. You're better off designing all your methods before you actually begin the project. So let's go through each of the sections. First, the methods: population, strict inclusion and exclusion criteria, and you need to list who was excluded and why. Surgery was an exclusion. 8 patients were excluded who had surgery. Less than 18 was an exclusion. 5 patients were less than 18. Claustrophobia was an exclusion. No patients had claustrophobia. You need to list that. Also, there's industry support to study, because that affects the population that you select. It's a very nasty business when industry supports the study. A lot of people will say Group A had an age range of 0 to 100 with a mean of 50. Group B had an age range of 49 to 51 with a mean of 50. And they'll say they were age matched because the means are the same. But they're not age matched. Age matched means patient A and patient B are within 5 years of each other. So the means of the two populations could be the exact same within a day, but they're not age matched. Also very important to say how long the study has been going on. Not just how many years, but when you began the study. Was it began in 1972 from 73? Because medicine was practiced very differently in 72 and 73. Hence the patients who came for this type of imaging technique would have been very different. So you have to list the years. Now, it's very important to try and get a control group. So let me give you a study and you're going to answer me which is the best control group. You ready? I'm doing my study on carbon spectroscopy of soft tissue tumors, of osteosarcoma. My control group could be carbon spectroscopy of chondrosarcoma, A. My control group can be carbon spectroscopy of paraosteosteosarcoma, B. Or my control group could be carbon spectroscopy in the normal population. No tumor. Who votes for A? Chondrosarcoma. No one? Who votes for B, parasitosarcoma? No? One person? No? Who votes for C, normal population? Okay? You were all incorrect. The best control group is the one closest to your population. A normal control group is almost never your best control group. That's why I said you could write the 102nd paper and still be better. They picked the wrong control group. So if you want a control group, they should be identical to your experimental group in every way but one. And that's your best control group. Hence, normal patients are usually never a good control. You understand that? Very, very good. Be careful as to what's a method and that's a result. Age can be either a method or a result. So if I'm looking at MR rotator cuff tears, my age is important because that's part of my inclusion criteria. If I'm studying paraosteoasteosarcoma, my age is a result because it tells me it occurs in younger patients. So be careful about what's a method and what's a result. Your results and methods should follow each other. So my first result should follow my first method. And you should go back all your results and make sure there's a method to match it. In the papers I review, 80% of them have a result with no methods to match it. You cannot give too much detail in methods. Your method should allow someone to reproduce your study without speaking to you. It's highly, you know your study, you know what you did. And subconsciously, your brain is filling in the gap that you don't write down. So a method should be robust enough so that someone reading the paper should be able to do identical to what you do. And we spoke a lot about this image analysis already, so I won't speak about that. But if you ask my advice about how to do a study better, that's the way to do it better. The image analysis part was methodology. Standard of reference. Avoid the term goals. Histology is obviously the best, but is often not available for practical reasons. But the best way to do a standard of reference is to see what other authors have used as a standard of reference. And it's better to say, as been previously done, reference 1, 2, and 3, we use blank as our standard of reference. Now, sometimes you use what's called a truth panel. And a truth panel is to avoid verification bias. So I was doing a study on the margins of tumors, and I'm comparing two sequences for the margins of tumors. And someone suggested using histology as a gold standard, and I said, no, I can't. Because histology doesn't look at all the margins. And even if they did, I wouldn't be able to correlate my margins on imaging to the margins of histology. So I used the truth standard. I had an orthopedic surgeon, a radiologist, and a pathologist sit together with all the data and mark all the margins and determine what they thought of each margin. And that's called the truth standard. And you do that to avoid the possibility of verification bias. Now there's also a concept that many radiologists are not familiar with, which is called non-inferiority. I'm inventing a new drug. This is a new cholesterol drug, and the most popular cholesterol drug is Lipitor, right? I want to have a new cholesterol drug, and I want to test this new cholesterol drug. But my advantage of this new cholesterol drug is it has no liver toxicity. And we all know Lipitor has liver toxicity. So it has an advantage. So as long as my new drug is no more than 15% worse than my old drug, but can't even be 15% worse, it's considered better. And that's non-inferiority. So if a test is better for non-radiology reasons, cheaper, faster, more available, less prone to breakdown, whatever the reason, it doesn't have to be as good as the old test. It just can only be a little bit worse than the old test. And that's called non-inferiority. So if I develop a new MR scanner that costs $100,000, and I prove it's 85% as accurate as the old MR scanner, I should buy that new MR scanner. And that's called non-inferiority. And radiologists don't use that enough in their analysis as well. Results. We've only got a few more minutes left. Results go from broad to narrow. That's just the easiest concept about results. Your results get more granular as you go down. Never include percentages if you don't include raw numbers. You must have raw numbers. And always cross-check your methods with your results, and your results with your tables, and your results with your figures. Again, statistical analysis, almost impossible to do by itself. It has to be robust, but try and speak to a statistician before you begin your test. They're very useful in terms of organizing your data. In terms of statistical analysis, you also try and include not only type 1 error, which is your p-value, but type 2 error, which is your confidence interval. I don't have time to get into that. But two or three things I want to mention about statistical analysis, and then I just have 2 more slides. Number 1 is ROC curves. Radiology is relatively unique in that we have ROC curves, and there's various more advanced versions of ROC curves. So when things are subjective, use a confidence scale to allow you to develop an ROC curve. Concept number 1. Anytime you say something was not statistically significant, you can't just say that. You have to prove the negative. We have very rigid criteria for you proving the positive. That's a p-value. But you have to prove the negative, and that's called a power analysis. So if I said A was not associated with B to a power of 1,000,000 patients, that counts. If I say A was not associated with B to a power of 100 patients, that just meant I didn't have enough patients to prove they were associated. So number 1 is ROC curve. Number 2 is power analysis. Number 3, there's a difference between statistical significance and clinical significance. And let me give you an example. So statistical significance is less than 0.05, right? That's statistical significance. So what if I said to you, you walk across the street, you got a 4 in 100 chance of being hit by a car. Would you walk across the street? No. You would find a different way of walking across the street. And that's clinical significance. Now what if I said to you, there's a 95% chance that this chemotherapy will work, but even if it does work, you're going to have renal failure. There's a 89% chance that this other chemotherapy will work, but it does not cause renal failure. Which would you choose? The second one, but the second one is not statistically significant. So remember that statistically significant doesn't mean clinically significant. You have to put that into context. Those are the 3 things I want to say about statistics. And I just want to finish up with discussion. Now discussion, an introduction does what? An introduction to a paper introduces the idea. Not the disease, not the technique, the idea. The logic that got you to the point of the idea. The discussion puts your results in context. It compares your results to others' results. Explains why, the best you can, they're different than other people's results. And be broad when comparing to other people's results. So someone will say, for the first time, we used whole sequence Y and rotated cuff pairs. Well, I sequence Y for meniscal tears, for Achilles tears, for renal failure, for adrenal lesions. And that might be the comparator. So be broad in what you compare your results with. Be modest. No study changes medicine. Period. Medicine is evolutionary and gradual. So don't say, this results will have a huge impact on the way renal failure is diagnosed in the world. I will completely delete that sentence. No study changes medicine alone. Almost no study. Maybe one study is 85 million people in Egypt, maybe 1 out of 85 million do that. Say your limitations and explain whether this has internal validity, which means the defects in how you designed your study, that your limitation has internal validity, and then external validity means why is this population applicable in general or why isn't it? That should all be in your limitations. And your conclusion is an equation. So your conclusion equals my results plus everyone else's results minus my limitations divided by the importance of the disease. That's your conclusion. It's an equation. My results plus other people's results minus my limitations divided by the importance and frequency of the disease. So in the last 40 some odd minutes, we've discussed some backgrounds about how to think of an idea,